You're watching Healthbeat, Bigasisa's monthly television program. I'm Mia Malan. In this episode, we're looking at the mental stresses associated with lifelong conditions like HIV.
It is a struggle. It is getting yourself mentally prepared to take medication for the rest of your life.
People with HIV have a higher chance of developing mental and anxiety disorders, and depression is one of the most common. This is because some types of HIV-related illnesses can affect the brain, and certain types of HIV medication may have side effects which can influence mental health. HIV-positive people also face the stress of having to take treatment for the rest of their lives and are often stigmatized. Later in the show, we'll be discussing a plan for nurses, and not just doctors, to be allowed to prescribe antidepressants.
We gained more confidence with the drugs, and nurses at primary healthcare clinics started to initiate the therapy, and we realized that that was safe.
But first, we visit Yvette Raphael from Themba to understand the stress of living with a lifelong condition.
Clothing store owner Yvette Raphael has lived with HIV for almost a quarter of a century.
Sometimes I don't feel like taking my meds because it is just so tiring.
The 48-year-old activist and fashion designer didn't think she'd still be taking medication so long after being diagnosed. She thought she would be dead.
The rest of my life looked like 5 years, and this is 20 years later because I started treatment the minute I found out I was HIV positive. I also know a lot of people will be affected if I decide not to take treatment and I die because I got sick. So I would feel guilty about that.
For the past 22 years, Yvette has had to take ARVs each day at the same time. The pills keep her alive, but taking them comes with challenges.
It is a struggle. It is getting yourself mentally prepared to take medication for the rest of your life.
People with HIV are up to 8 times more likely to have depression than the rest of the population. And when they're depressed, they're also less likely to stick to their ARVs. Yvette says today there's less mental health support for people with HIV than in the early 2000s.
Initially, we had support groups, the most safest spaces where we could talk about, my husband does not want to use a condom, where people would say, my boyfriend treats me badly. He goes into a next room after us having sex with a condom and he takes a shower.
Yvette sees her shop as a safe space for herself and others.
A lot of advocates come, activists come and chill around this space, come and buy clothes, but that chair that you see there is intentionally made so that you feel comfortable. There's a couch where we can talk about where this fabric comes from, but also how are you? How are you dealing with stuff? How are you dealing with the difficult work that we do in advocacy?
She herself might have given up, if not for her family.
I actually call my husband the treatment police, the ARV police, because he does not forget. Every morning before I open my eyes, my meds are there, and he is such a great support.
Yvette says unemployment and anxiety go hand in hand for people with HIV. Taking lots of sick leave can mean losing your job.
This illness doesn't care. You would go down to get so sick that you are unable to be employable. There's nothing more frustrating than not being able to provide for your kids, not being able to have food so that you can eat and drink medication.
She believes helping people with HIV cope with depression is about more than prescribing antidepressants.
I don't think pills are the answer. I don't. We have to do a little bit more. I don't think we think around enough creating spaces for people living with HIV where they can just talk around the challenges that they are going through.
Even on treatment, there's still a chance that HIV could affect your brain or central nervous system, and that has implications for your mental health. Joining me from Cape Town via Zoom is Professor John Joska from UCT's HIV Mental Health Research Unit. John, thanks very much for joining us today. How does HIV affect your brain or central nervous system?
The brains of people with HIV may be affected directly by the virus or indirectly through psychological and social effects of living with HIV. We've known for some time now that while HIV infects mainly the white blood cells known as CD4 lymphocytes, these cells may enter the brain quite early after someone gets infected. And what may happen then is a chain of events driven by infection and slow inflammation of the brain tissue. So in the days before ARVs, these people would develop AIDS with all of the symptoms and signs, as well as a syndrome known as HIV encephalopathy, which is an acute confusional state. But fortunately, these days, this is quite rare. And so what more often happens is a slow and gradual loss of brain tissue due to the inflammation before the person starts their ARVs.
John, if you take antiretroviral treatment, does it make it harder for HIV to get to your brain? In other words, does it cause less inflammation?
So ARVs are absolutely crucial to brain health in HIV infection. And when taken regularly, they will result in the clearance and suppression of HIV from all body compartments, even the closed environment of the brain. So when the brain tissue is clear of HIV, then the cycle of events leading to this inflammation that I spoke about and the brain tissue damage is essentially halted. And these brains, to all intents and purposes, are returned to normal apart from any damage that might have occurred before the ARVs were started.
Now, if you look at the ARVs, are there any side effects that could possibly also impact on your mental health or affect your brain?
So again, just to emphasize and to begin with, that taking ARVs is overwhelmingly better for brain health than not taking them. But we have been studying the neurologic effects of the ARVs ever since they've been used. And some of them are known to cause side effects to the brain and the nervous system. For example, the drug efavirenz, which until recently was a common component of our national triple therapy regimen, may cause sleep changes, nightmares, depression, and anxiety, especially in the first few months of treatment. There's also been a question mark around whether efavirenz may impact cognitive functions. And in our group in Cape Town, we have done some research on efavirenz, and we think that people who take it are more likely to perform poorly on cognitive testing than people who don't have HIV infection. So the program nationally has switched from the efavirenz ARV to the dolutegravir ARV, and we think this is a major advantage for brain health.
To get back to the effects that HIV has on your brain, is there any medication, psychiatric medication, that can be taken to counter this?
It is possible that people may experience a change in their mood or have high levels of anxiety or in fact have cognitive symptoms such as poor memory. And they should report this to their clinician, who might be a nurse or a doctor. And then the first step would be to ensure that they are suppressed. The second might be to consider switching an ARV. So if they're on efavirenz, for example, to switch them to dolutegravir. And then if clinical symptoms of depression or anxiety are persistent, then one might consider using psychotropic medications such as antidepressants, or to refer the person to a psychotherapist or a counselor to receive the care that they need. And also just to say that we know that alcohol and substance use problems are very common both in the general population, but of course also in people with HIV. So it's important to address that mental disorder as well.
John Joska, thanks very much for joining us today.
You're very welcome. Thank you.
That was John Joska. He's the head of UCT's HIV Mental Health Research Unit. After the break, we talk to a psychologist about the effects of stigma on someone's mental health. Stay with us. You're watching Healthbeat, Bigasisa's monthly television show. We're looking at HIV and mental health. With me is Marnie Vujovich, a psychologist at the Themba Lethu Clinic in Johannesburg. Marnie, thanks very much for joining us today. It's hard to believe that stigma still exists after all these years. Why is that?
I think stigma, unfortunately, as you say, is still alive and well, but it's important to differentiate between externalized and internalized stigma. So if we think about externalized stigma, that has changed, and I think it's decreased. And that's the stigma that involves stigmatization by people in the community. Whereas internal stigma is the stigma that a person has when they consider themselves unworthy, contaminated, and have real self-esteem problems as a result. So I think for young people, there's tremendous difficulty in disclosing status. We still don't speak openly and freely about HIV, and it makes it very difficult for them to really feel comfortable in talking about HIV as it is, a chronic illness and nothing more than that.
So treatment has changed HIV from the death sentence that it was 2 decades ago, and now it's a chronic condition. But it's tough to take treatment for the rest of your life every single day at the same time, right?
We often talk about treatment fatigue, particularly when it comes to children who were perinatally infected, so through mother-to-child transmission. And they've been on treatment for many, many, many years. And they reach a point when they begin to think, this is enough now, I want a holiday, a drug holiday. For others, it becomes routine. It's like brushing your teeth or washing your face. You know, it's something that you do every day. One of the things that has happened is we've become more kind of flexible and less rigid in terms of when you take your treatment. Obviously, you should take your treatment as soon as possible to the time at which you usually do. But we understand that young people have busy lives, that they are occupied with schoolwork, that they're out socializing. And if there's a situation where they haven't taken their treatment, we're advising now you take it as soon as you remember.
If you do struggle to adhere to your treatment, whether you're young or old, say you've lived with HIV for a long time, and you now want a drug holiday, how do you counter that? What do you do?
We encourage treatment reminders. When a young person first starts on ARVs, we'd sit down with them, and again, it's a treatment plan. And find ways in which to help them remember. So what would an appropriate treatment reminder look like to you? Would it be a cell phone reminder? Would it be a TV program? Would it be a little sticker on the mirror? So when you go to brush your teeth, you see it there and you're reminded. And would it help to have a treatment buddy, somebody who knows your status and you'd feel comfortable if they kept in touch with you and reminded you?
Marnie Vujovich, thanks very much for joining us today. Marnie is a psychologist at the Themba Lethu Clinic in Johannesburg. After the break, we look at a government plan to make depression and anxiety drugs more accessible. Don't go away. You're watching Healthbeat, and we're looking into ways to make antidepressants more accessible. Currently, professional nurses in South Africa can't legally prescribe psychiatric medicines. But the country's latest HIV plan will change that. The plan says nurses have to be trained to prescribe meds for certain mental health conditions. But before that can happen, the law and a whole set of regulations need to change. Pharmacologist Andy Gray explains.
The first change that has to be made is that the Minister of Health has to change the regulations that govern which schedules the nurses have access to. Medicines that nurses can currently prescribe predominantly in the public sector. That is limited to medicines in Schedule 1 to Schedule 4.
The higher the schedule of a medicine, the stricter the rules are for how it can be dispensed.
The simplest, the Schedule 0, are the medicines that you can buy in any retail store, in a spaza shop or a cafe. Then we get into increasingly strict control as the numbers go up. So Schedule 1 and 2, you can buy in a pharmacy. Schedule 3, 4, 5, and 6 require a prescription from an authorized prescriber, like a doctor. And then Schedule 7 are the ones that are banned.
Mental health drugs mostly fall under Schedule 5, which is why nurses can't currently prescribe them. Gray says changing the rules shouldn't take too long.
The normal process is that the minister publishes a draft regulation for comment, usually for a 3-month period, and then it gets finalized. This could be fixed in a matter of months if there was the political will to do it.
The minister doesn't decide alone. The Nursing Council, which oversees professional nurses' conduct, has a say too.
So in this regard, it has to make a recommendation on the wording of the regulations to the minister.
But the work doesn't end there. Psychiatric drugs need to be prescribed with the history of individual patients in mind.
So Schedule 5s have an abuse potential, not as strong as Schedule 6s, which would be something like morphine. But if you think of the medicines that we do use for anxiety, those can be misused by patients, and so there's stricter control over them.
This is why nurses will need psychiatrists to mentor them once they're allowed to give mental health meds.
And that mentoring is going to be really important, not only during the training, but as an ongoing referral mechanism for those nurses who will be asked to take care of patients with mental conditions.
Gray says updating regulations is only the first step.
There's also an opportunity for the Nursing Council to stipulate particular training programs for nurses who can then get entered into a specialist register. And we could then include medicines for those nurses specifically in the schedules. But that is a more complicated process. However, I think it's the right longer-term solution.
So, psychiatric medicine may become more accessible. But this is not a new concept. It's happened with other drugs too. 13 years ago, only doctors could prescribe HIV treatment. Now nurses can do that too. And in August this year, the Pretoria High Court ruled that pharmacists be allowed to dispense HIV treatment and prevention pills without a doctor's script. Would this make it easier to stick to antiretroviral treatment? Professor Francois Venter is a doctor who has lived through HIV for the past 2 decades with his patients. He's also the director of Ezintsha at Wits University and joins us now. Francois, thanks very much for making the time to join us today. Does making medicine easier to access necessarily lead to patients taking it more consistently?
Yes, I think that, just making the whole transition from knowing your diagnosis to, learning your status in terms of access to the medicines, and then just being able to pick up your medicines, that whole transition is really important. Easier is really important. And we've learned that, getting your diagnosis fast, starting the treatment, usually on the same day in South Africa, and making you get your medicines from somebody who knows what they're doing, and then picking up the drugs in the same place near your home, actually facilitates people taking their tablet. And we've got millions of people now successfully on therapy because of that.
So take us back to that time before nurses were allowed to prescribe antiretroviral drugs for HIV.
So when the state program started on the 1st of April 2004, it's like yesterday still for me. We started initially in hospital clinics. Doctors would initiate the therapy. There'd be quite a big deal about adherence in many parts of the country. People would often come back for months before they were started. and there'd be a big song and dance in terms of the starting. Lots of blood tests, lots of adherence visits. And then when patients were ready after they'd been diagnosed and they come back a couple of times, they would have their drugs prescribed by a doctor. And then they'd come back several times as the drugs would take hold, and finally they'd get a couple of months of therapy and 3 months at a time. And finally, in some places, they get it up to 6 months at a time. So it really was a big process. And it took us a long time to get up to 100,000 patients, you know. And the big scale up took place when we started to move across and said, no, nurses can do this, you know, and that also was a bit of a process. Nurses could do this, and counselors could diagnose. Their counselors could make the diagnosis. We gained more confidence with the tests, we gained more confidence with the drugs, and nurses at primary healthcare clinics started to initiate the therapy, and we realized that that was safe. And now we're in the era where we're saying even pharmacists must be able to prescribe these drugs. And I think this is a whole transition to saying the drugs are so safe and so good that we should be trying to get them to the lowest level possible.
So clearly making that shift from a very high level of health workers such as a doctor to lower levels such as nurses and pharmacists has helped us to make these drugs more accessible and to put more people on treatment. Do you think we'll see the same benefits in the case of psychiatric drugs?
I hope so. I mean, we still have a situation where mental health is grossly underdiagnosed and grossly undertreated. And we need to be pushing these therapeutics into the hands of people who are able to firstly diagnose and secondly be able to dish these things out. We don't have nearly enough doctors in this country. We don't have enough nurses, to be quite honest. But if we keep saying it's going to be left in the hands of the highest tier of medical care, it means the people who need them are not going to get access to them in the private sector and in the public sector. So we really need the same approach to mental health that we have to HIV. And I think that's what HIV has taught a lot of chronic diseases.
If we make these, as you say, therapeutics or antidepressants or anxiety drugs more accessible, isn't there a danger that it can be abused?
People are often concerned about this, and I think you just need to be sensible. You need to look at which drugs you're dealing with. What are the dangers? All drugs have side effects. You look at them and you say, what are the benefits to the society and what are the harms? And you put you're good with the training with the people who are handing them out. And you say, this is what the indications are for. ARVs are a very good example. I think the same thing needs to be done with each crop of mental health drugs. And some of them do have problems with them that need to be put in the right hands. And perhaps that's a group that there might be ones that only rest in the hands of psychiatrists. There's some that might need to be only handed out by doctors, but there are many that can be handed out by lower tiers of medical staff that can safely hand them out and people can get a lot of benefit from.
Francois Venter, thanks very much for sharing your insights.
Thank you.
Living with a chronic condition can be tough on the body, but it's also tough on the mind. And making it possible for nurses to prescribe mental health medication might just make that journey a little bit easier. That's your Health Beat. Until next time, goodbye.